So for our first talk, we're going to have a collaboration between Stanford University and the University of Utah, presenting individual and program-related predictors of academic vascular surgery practice, presented by Andrea Fisher and co-authors.
Good afternoon, and thank you for the opportunity to present our work. Thank you also to Dr. Smith, who enabled our collaboration with the APDVS. We have no disclosures. About 1 year ago, I was applying for integrated vascular surgery residency positions. I and many fellow applicants were hoping to go into academics after training, and we wondered which programs would best set us up for success as attendings. Are research years important? How much should we aim to publish during residency? After starting residency, I was granted a glimpse at the program side of the recruitment process. A number of programs, ours included, are interested in supporting trainees pursuing academic careers. Recently, more programs have been adding research or professional development years to help trainees develop as researchers, public health leaders, and entrepreneurs on top of being surgeons. What steps can programs take to best support aspiring academic surgeons? We had 2 research questions. Which elements of surgical training predict future academic productivity as an attending? And which training-related individual characteristics are common among NIH-funded attendings? To answer these questions, we conducted a retrospective review of all vascular surgery graduates between 2013 and 2017. We chose this time period because the first integrated residency class graduated in 2013, and 4 years of postgraduate time was deemed adequate to compare early career research output. The APDVS kindly provided the list of all graduates. For each graduate, we collected a number of variables, including completion of research years, publication rates during and after training, whether they had secured NIH funding, and their current practice setting. Academic affiliation was noted for each individual associated with a vascular surgery practice at an academic institution as specified on the institutional website. So for instance, a surgeon practicing in a university-associated VA hospital or county hospital would be included. We also noted characteristics of each vascular surgery and general surgery training program, if applicable, including whether each training program had high levels of NIH funding. In order to collect data, we used publicly available resources including Doximity, LinkedIn, and institutional websites for educational history and employment history. Scopus and PubMed were used to obtain publication rates during and after training, as well as H-index. To determine whether a program had high NIH funding, we used the Blue Ridge Institute for Medical Research database. For each year, we sorted institutions by the amount of NIH funding each department of surgery received. Any institution that fell within the top 10 for surgical NIH funding within at least 1 year, from 2010 to 2020, was designated as having high NIH funding. And the 34 institutions on the right are the resulting list. Individuals were categorized as having trained in a well NIH-funded program if they completed general surgery, vascular surgery fellowship, or integrated residency at one of these places. We first conducted univariate analyses using Fisher exact tests and t-tests to determine which type of training variables correlated with each marker of academic productivity. So these were academic employment after graduation, publications per year as an attending, and H-index greater than or equal to 5. Training-related variables of interest included type of medical degree, dedicated research time, advanced degree, training at a top NIH-funded surgery program, number of publications by the end of training, and H-index. H-index as a predictor was obviously excluded for analyses of H-index as the outcome. We then ran adjusted multivariate regression analyses for each marker of academic productivity, including each training-related variable with p less than 0.05 correlation on univariate analysis, as well as vascular surgery training paradigm and number of years in practice. Our overall cohort included 724 graduates, 603 of whom completed fellowship, and 131 of whom did integrated residency. 29% of these graduates were women. In the 2021 to 2022 year, there were 134 vascular surgery training programs. 120 of these offered fellowship, and 69 offered integrated residency. A plurality of integrated residencies are found in the Northeast, or 34.8% of programs, and a plurality of fellowships are located in the South, or 33.3%. We found that the odds of academic employment after graduation were predicted by an individual's number of papers by the end of training, whether they had advanced degrees in addition to an MD or DO degree, having an MD degree, current H-index greater than or equal to 5, and having trained at a program with high NIH funding. Graduates who had completed research years during vascular surgery or general surgery training had increased odds of publishing more than one paper per year as an attending. We did not observe any correlation between research years and current academic employment, or H-index. Attendings who published more than one paper per year also had a higher likelihood of coming from a program with high NIH funding and having an additional advanced degree. Current H-index greater than or equal to 5 was associated with a surgeon's number of years in practice and the number of papers they published by the end of training. Fellowship versus integrated residency was included as a variable in analysis of each outcome, and we noted that training paradigm made no difference in any measure of academic achievement. Finally, a subset of 33 graduates have secured at least one NIH grant. Of these, 72% completed dedicated research time during training, and 79% trained at a top NIH-funded program. The mean number of publications by the end of training among this group was 15.8. Research outputs as attendings were even more substantial. Subjects averaged 4.3 publications per year, with a mean of 32.6 total publications since graduation. Although the majority, or 59%, hold academic positions at institutions with which they have no previous affiliation, 30% stayed at their vascular training program as faculty. We found that trainees who earn advanced degrees and publish more in training tend to become academic attendings. This is unsurprising, as a strong research background is somewhat prerequisite for academic employment. Our findings also show that a department's NIH funding appears to propel graduates to academically prolific careers. Likely, this is because NIH funding signifies strong research mentors at a given program, and greater institutional resources often translate to more research support per trainee. For applicants debating the merits of general surgery plus vascular fellowship versus integrated vascular residency, it might be reassuring to know that neither paradigm is superior in preparing graduates for an academic career. For the impact of research years, we found that although graduates completing research years tended to have higher publication rates during and after training, they entered academics in no larger proportions than their fellow graduates who did not take time off for research. However, the large majority of NIH-funded surgeons did complete research years. They also tended to be well published during training, suggesting that dedicated research time was likely instrumental in building an academic portfolio. For a select trainee population, it seems that research years are vital to launching a surgeon-scientist career. Our study had several limitations. There is a large degree of practice variability under the umbrella of academic affiliation, with some surgeons running a full basic science lab and some surgeons devoting the majority of time to clinical practice. At the risk of limiting our sample size, we might find stronger correlations if we reanalyzed our data, including only those surgeons with a professorship as compared to those with an institutional affiliation. Our data set also represents the earliest graduates from integrated residency programs, and the structure of integrated residency has been evolving since its inception. Current residents may find themselves in a different practice landscape in a few years compared with predecessors. Finally, conclusions about the value of research years are complicated by the fact that they tend to be offered at research-heavy institutions. This may obscure the independent effect of research years. We hope that these findings will provide guidance to applicants aspiring to research-focused careers and programs hoping to ready trainees for academic practice. I'll now be happy to answer any questions.
Excellent, thank you, Dr. Fisher. If anyone has any questions, please get to the microphone. In the meantime, I'll ask you a couple of questions if you don't mind. So I think it's important when you mentioned this academic affiliation, and maybe good to specify when you do your manuscript that academic not only means people that writes papers and have NIH funding. I think nowadays is so diverse and variable. You can have academic surgeons that are quality officers that are high in administrative roles and may not be having scholarship from there. So something to mention there. So did you mentioned that you looked at NIH funded institutions. Were you able to determine if they were NIH-funded departments or sections of vascular surgery?
So we did it by department of surgery. We weren't able to get the granularity for vascular, but they do have by department.
Okay. Were you able to tell if those medical students that matched into those highly funded, NIH-funded institutions had any kind of prior research experience?
We actually would be able to go back and tease that out. We did collect research we lumped in during trainings like medical school,
right,
undergraduate, the basically publications up until you graduated from training. So we could see if the people who went on to become academic had that background from undergrad and medical school even before.
Right.
Yeah.
I'll ask you one question since I have somewhat knowledge of the training paradigm. So my impression is that there's some level of self-selection, right? People who go to an institution like Stanford are more inclined to be an academic in the future. So instead of, I think what you should do, or somewhere in the future might be looking at those that are at the lower side of NIH funding and what promotes those residents to go into academic, right? Because the opportunities that you have are vastly different than opportunities that some others may have. And it's hard for us sometimes when we're not, or after that, to appreciate it. And I think it would be very interesting if there's any way to survey, I couldn't come up with it on the top of my head, but to see what promotes those at a lesser NIH funding or less place to go into academics and publish more and what they have to do. So just a comment, but excellent talk. Thank you very much.
Excellent. Thank you.